The voice, Curtis P. Arts of the Medical University of South Carolina School of Medicine, introducing the topic to be discussed and the surgeons to be consulted during this 60 minutes of Audio Digest Surgery, Volume 18, Number 4.
Our panel today consists of individuals who have had varying experiences in the treatment of burns, and I'm pleased about this because there are many acceptable ways of treating the burn patient, and I hope all of you are here to learn one or two additional ways that might serve you when encountered by a severely burned individual. Dr. Baxter, an associate professor of surgery at Southwestern Medical School of the University of Texas. Dr. William Monifo from St. John's Mercy Hospital in St. Louis. Dr. Ron Olstein, chief of the new New York City division of the New York Burns Institute. He is also at St. Vincent's Hospital in New York. And Dr. Basil Pruitt, Colonel Pruitt, head of the famous Surgical Research Unit in the Army Burn Center at Fort Sam Houston, Texas.
And on side A of this program, varying views on treating the burn patient. Dr. Pruitt provides pointers on fluid replacement during the first and second 24 hours and after 48 hours, followed by a group discussion of local burned wound treatment. And on side B, Dr. Charles R. Baxter with important considerations regarding post-burn nutrition, Dr. Olstein describing the preparation for and technique of skin grafting, and Dr. Arts concluding the program with a question and answer session. Now, once again, Dr. Arts in his role as program moderator.
The first individual to present is Colonel Pruitt, and I've asked if he would discuss fluid therapy.
The pathological change following thermal injury is one of coagulation necrosis. In areas of both cell death and cell injury, this results in an increase in capillary permeability. This is manifested clinically by the edema with which we're all so familiar. This in turn results in a decrease in blood volume, increase in peripheral resistance, and a decrease in cardiac output. It is these hemodynamic alterations which one seeks to either minimize or obliterate by administering resuscitation fluids. Since 1947, several formulae have been advanced to guide therapy, including Dr. Monifo's hypertonic electrolyte resuscitation, which he has recently described in a small number of patients. The number of formulae attests to the therapeutic latitude which exists within burn patients, and also attests to the great debt which historically we owe Dr. Moore, Dr. Evans, and of course our chairman, Dr. Arts, for having put this on a scientific basis. Any formula properly applied by the guidelines laid down by the authors has been found successful, and it's important that one apply that formula with which he is most familiar and with which he has had the most experience. I have had the most experience with the Brook formula, where the amount of fluids estimated depends upon the extent of the burn, and one would estimate, and I emphasize that this is an estimate that is altered according to the individual's response. And it is calculated by multiplying 1.5 cc's of electrolyte-containing fluids times the patient's body weight in kilos times the percent burn, that is total of second and third degree burn. Colloids we administer in 1/3 that quantity and add also 2,000 cc's of dextrose in water to cover metabolic needs and evaporative water losses. This is administered such that the patient receives half in the first 8 hours post-burn during the time of most rapid edema formation, and a quarter in each of the two succeeding 8-hour periods in the first 24 hours. I hasten to emphasize again that this is altered according to the patient's response in terms of both volume and rate of administration. And I would emphasize that recent physiologic studies have pointed out that in the first 24 hours, volume replacement is largely volume dependent. That is, that the rate of administration appears to be in excess of 4 cc's per kilogram per hour in patients with large burns. The second 24-hour needs 1/2 to 3/4 of the first 24-hour period. And again, 2,000 cc's of glucose in water. Now, I have emphasized that this is altered according to the patient's clinical response and the common means of assessing adequacy of any resuscitation program, the importance of frequent clinical observation of the large burn patient who cannot be adequately treated by telephone, as of course we all know. The hourly urinary output, despite its many theoretical limitations, has proven to be a very handy clinical guide for adequacy of resuscitation, and we aim for 30 to 50 cc's per hour in the adult and correspondingly less in the pediatric age group. Oliguria in the first 48-hour period is only rarely due to acute tubular necrosis. And the treatment, of course, would not be limiting fluids, but more vigorous fluid administration. There are, however, 3 groups of patients in whom we feel osmotic diuretics are indicated, namely patients with significant electric injury, patients with associated muscle necrosis, both of these groups having large loads of hemochromatogens in their urine and predisposing them to acute tubular necrosis. And then lastly, those few patients with large burns who receive what you estimate to be their fluid needs and also additional fluids and remain oliguric. I think it's important to point out that having administered mannitol, these patients will continue to secrete urine despite volume deficits, and the urinary output is no longer a guide to adequacy of resuscitation, and one must then rely upon other clinical indices. After the first 48-hour period, the patient's fluid needs are largely those of electrolyte-free water to cover evaporative water losses, which we'll discuss in a moment. We avoid potassium supplementation in the first 48-hour period because of the frequent elevation of the serum potassium consequent to tissue death in the presence of an often depressed urinary output. We also avoid giving whole blood in the early post-burn period because of the increase in capillary permeability. The fluid components of the whole blood would leave the circulation, and the retained red cells further elevate a usually elevated hematocrit. Only those patients with associated other injury and exogenous blood loss should receive whole blood in the first 48-hour period. Even beyond 48 hours, it is not uncommon to have an elevated plasma volume, and if the patient requires red cells, we would prefer giving packed cells in that situation. The main fluid needs after 48 hours, as I mentioned, are usually electrolyte-free water. One can estimate the evaporative loss clinically by employing the formula of 25 plus the percent burn per meter squared in cc's per hour. That is an estimate at the low end of the scale. Since this is 85% free water, it should be given in the form of glucose in water. The clinical guides to adequacy of hydration are body weight, osmolality, and serial serum sodiums, one can vary or adjust the amount of fluids given to replace evaporative water losses.
Dr. Pruitt, do you use central venous pressure to monitor your fluid therapy? Is that better, or does it do you any good if you're able to measure urinary output?
As I indicated, I feel that the patient's urinary output is a handy clinical guide. If one has a central venous line in place, it is a very helpful adjunct and is perhaps best utilized in the very young and the very old, in whom one needs perhaps to monitor their hemodynamic status more closely than the young adult.
It's pretty obvious from that we haven't changed a lot in the last 10 years on fluid therapy. Let me ask Dr. Baxter to comment on fluids, because I think he has a few new and different ideas. Charlie?
I'd like to just emphasize a couple of points that may be a little bit covered in an attempt on Dr. Pruitt's part and mine too, of not pushing a far out or radical approach which you're not used to, or anyone is not used to. I don't think I could resuscitate burns as other members of the panel do and so on, nor they like me. In the studies that we have been doing over the past 7 years, I think one thing stands out, and that is that the rapidity of fluid loss is much faster than we've been led to believe by replacing fluids according to clinical signs. Or in essence, our studies really show that the majority, if not all, of the fluid sequestration into the burned area is in the first 24 hours. And by using 48 hours, we are playing catch-up, so that we attempt, and have been for the last several years, giving the entire quantity in that period of time with quite good beneficial results. I think also that it's less important what particular solution one chooses, as long as you give enough of it and fast enough.
Now let's go on to another phase of burn care, primarily initial local treatment. Bill?
We traditionally being for the last 5 or 6 years, have been using silver salts of various types as the major topical form of therapy on major burn wounds. Recently, we've become interested in the work of Janisovic in Yugoslavia and Mr. Jackson in England. These two people, I think more than any other, have recalled interest in the so-called tangential excision of major burn wounds. Our approach to the early excision of large volumes of devascularized tissue with, I think, a few extra twists, things that perhaps haven't been tried too thoroughly before. Dr. Arts has extensive experience with formal surgical excision of burn wounds, and as some of you may know, this in general has been abandoned for large wounds because it has not been shown to significantly decrease the morbidity and mortality rates that attend. What we have tried to do is to capitalize on the fact that deep burns, deep second-degree burns and obvious full-thickness burns are characteristically anesthetic for the first several days following injury. Using this piece of information, plus the knowledge that most major burn wounds are essentially bacteriologically clean, sterile, literally sterile, for at least the first few days following treatment, provided that one has effective topical antiseptic agents covering those wounds. We have been excising selected areas of deep burns, excluding the face and hands, without anesthesia during the first 72 hours. The procedure is done in the hospital bed. It is done on individuals whose wounds have been proved to be bacteriologically sterile. The instrument we've selected after a number of tries has been the little dermatome that Goulian has described. Blood loss is very minimal if one carries the tangential excision to the point where capillary bleeding begins and then stops. As the technique has evolved in our institution, we have come to the concept of immediate coverage of the freshly excised wounds with either cadaver homographs or porcine heterograft. I'm not recommending that this be done generally. The reason I presented this is to indicate to you what I think is a promising approach. It's really an old approach with a few new twists.
I think everybody's been very pleased with the use of pig skin if we put them on every few days. What's this every few days? Why do you change them every 3 days?
Because in our experience, if one leaves them on longer than that, the grafts will adhere so firmly that there will be vascular adhesions between the bed and the graft, and it's very painful to remove them. We found by trial and error that 48 hours is a reasonable period at which to change them without pain and without causing bleeding.
Yes, I think it's rather important that these be used not as grafts, and this is a bad term, but that they be used as biological skin dressings and put on and changed frequently before they attach themselves. I think we have to recognize that in trying to produce a panel on burns for you, we have in mind to present practical techniques, but in addition, we'd like to show you some of the new things that people are thinking about in this world. And I'll tell you, Dr. Yankovic, that I spent some time visiting with in Czechoslovakia recently, really does a fantastic job with a large Ferris Smith or Humvee knife and peeling off this dead tissue and then applying autografts immediately, not the heterografts as Dr. Monofo did, but autografts immediately. And in her hands, where she's done this for a number of years, she really is very expert. I doubt if there are many individuals in this audience or in this auditorium that should be doing tangential excision at the present stage of its development. I think there are a lot of other good ways for local care, but maybe tangential incision combined with some of our other techniques may be very valuable. Now I would like to ask Dr. Baxter how he treats the local burn wound. We probably have made more progress in local burn wound management than any other aspect of burn care in the past 10 or 15 years. Our local antibacterial agents have done more to salvage lives between 30% and a 60% burn than any advances we've seen in burn care, and I think this is worthy of discussion. Dr. Baxter, how do you manage the local burn wound?
At the present time, our approach is to use topical antibacterial agents, and we've used several over the past 5-7 years since they've become available, and based principally on the difficulty of telling the difference between a second and third degree burn wound. If we can protect what appears to be a third degree burn wound, it oftentimes will heal just with hydrotherapy. The usual picking debridement on the ward surprises one oftentimes in its ability to heal. We've been very conservative and have not employed, except on rare occasions and special patients, any sort of excisional technique. We feel that this has certainly netted some decrease in mortality, morbidity in terms of wound pain in and of itself, and at the present time this seems to be the safest and surest way that we can see for handling most burns.
Dr. Pruitt, what are you using at the Institute of Surgical Research now?
We've continued with sulfamylon topical therapy, and I would only want to emphasize the previous speakers in the area of that being the very crux of burn care, control of the bacterial population of the burn wound.
Well, now you're a colonel and you can put that miserable sulfamyl on all those poor soldiers. What do you do when the soldier says it hurts, Colonel?
Well, we have perhaps euphemistically said that it may be uncomfortable when applied to partial thickness burns. I think this is true. I think that it is important to realize that historically small second degree burns will heal spontaneously without any topical therapy, and its main efficacy has been in the control of invasive wound sepsis in the large burn, the large full thickness burn. And it is in these patients that it is effective, and it is in these patients with large full thickness injury that it is not uncomfortable. And this discomfort has never been the cause for our discontinuing sulfamylon therapy, and we haven't ordered them that it will not be painful.
I'm glad he made that point, because an awful lot of burns really doesn't need sulfamylon or any of the antibacterial agents that we talk about today. Small burns can be treated well by dressings, and most of us treat the outpatient burn by dressings, and if we keep the second-degree burn wound clean, it heals very, very well. Where we need the antibacterial agents are in the more extensively burned patients where you feel that sepsis is a real deterrent to the life of the patient or to healing of the wound. Now, I've heard a lot, Dr. Baxter, about it delays eschar removal. The eschar stays on longer with sulfamylon, and I've been quoted, and I believe correctly so, that it's malpractice to leave an eschar on more than 30 days. If at the end of 28 days or so, that eschar isn't just about ready to come off, you ought to do something about it and get a skin graft on, because so many patients go for 40, 60, 80 days and still are not grafted. Do you think sulfamylon or any of the antibacterial agents delays the spontaneous sequestration of the eschar? And if you do, what do you do about it?
Well, if it does, it's only very slightly. To show an increase in the hospitalization time of a major burn nowadays, I think attributes to the fact that more of them are living, not to how long an eschar stays on. You certainly can with a sterile eschar that's in part separated by proteolytic enzymes of the bacteria that are present. If this wound is sterile, certainly the eschar is going to be slower to separate. But with active debridement daily, as is absolutely necessary in the proper care of the burns, I don't believe that this is a significant factor with either sulfamylon, silver sulfadiazine, or 0.5% silver nitrate.
What was that new agent you mentioned, silver sulfadiazine? The local antibacterial agents in common usage in certain burn and clinical research centers are sulfamylon, silver nitrate, some of the silver salts, gentamicin, and silver sulfadiazine. Silver sulfadiazine does show some promise. It is not yet available to the general public. The silver salts are being investigated by Dr. Monifo. These are not yet available. Gentamicin, I think, has done very well in a number of burns, particularly when it is utilized under a dressing. I think it's been a great boon in this type of burn, but in many instances, the Pseudomonas has become resistant in large burn centers to gentamicin, and so I don't know really where we stand right now in this particular field. We have not talked about the use of systemic antibiotics initially, and I know you are all interested. You may find a split vote on the panel. Dr. Baxter, you use systemic antibiotic therapy?
Yes, we do, and almost always on specific indication. That is, when we feel that sepsis is occurring from another focus other than the burn wounds.
But do you use it prophylactically when the burn comes in the first 5 days?
We do still use penicillin in low doses for the first 5 days, principally because of the threat of streptococcal infection.
Dr. Monifo?
Well, we use, as Dr. Baxter does, prophylactic broad-spectrum penicillin drugs, not only for the first 5 days, but what we've done is give it in small doses throughout the convalescence in order to guard against streptococcal or staphylococcal lymphangitis. As far as specific therapy against organisms that might be recovered from the surface of the wound during the convalescence, we do not prescribe an antibiotic on the basis of a sensitivity test to a given organism unless the wound clinically shows deleterious signs or what we consider to be grave signs, or unless the patient has obvious invasive wound sepsis. In that case, we treat them.
Dr. Pruitt?
We also give prophylactic penicillin for the first 5 days. Thereafter, a systemic antibiosis is carried out only on specific bacteriological indication, which is frequently best guided by positive blood cultures and wound biopsies of any suspicious area, which would lead one to feel that the source of sepsis might be that patient's burn wound.
Boy, I'm sorry I asked that question. Every one of them disagreed with me. I have said since topical antibacterial therapy has become available that there is little need for isolation in the patient and that there's little need for prophylactic antibiotics. I have seen very few cases of the beta hemolytic strep in patients, except children, who were treated with local antibacterial agents, and I don't believe that one can better isolate the burn wound by gowns, by keeping people out. No other technique, in my opinion, is as good as covering that burn wound with a local antibacterial agent. I think it's a great type of isolation of that wound from the remainder of the environment. Well, it's obvious there are a number of ways. Some of us use simple exposure on certain burns of the face and hands that are second degree without any antibacterial agents. Some people use simple Vaseline gauze dressings on the small burn. It's treated as an outpatient, and these do very well as long as you change them every few days and you keep that wound clean. I believe we have agents in silver nitrate and sulfamyelon, which may be a little better to use, and now some new agents coming on that will diminish the number of bacteria in and around the burn wound and prevent that miserable burn wound sepsis with which many patients died several years ago. Now, does most everyone on the panel use the Hubbard tank or some type of tank in which to put patients? I think one of the great advances I have seen in local care is the fact that you put the patient in the tank, keep him moving, make him feel good, increase his appetite, prevent contractures, as well as cleanse the burn wound once a day in between local and bacterial changes. You use a tank, Dr. Pruitt?
Yes, we do.
Dr. Monifo?
Well, I guess I'm a bit unorthodox, Dr. Arts, but I'm very much afraid of the tank. If one cultures the bath water regularly after you put a patient with a large unhealed wound in there, one becomes, I think, a little more leery about putting them in. I'm worried about transfer of organisms from the perineum onto the wound, particularly in children who may or may not have bowel continence, particularly in sick patients who have the same difficulty. We, at one point, tried an elaborate filter and changing system in our tub in an attempt to keep the numbers of organisms at a low level, and we're unable to come up with a system that would keep the bacterial count in the bath water down. For this reason, we've come further and further away from the tub until the wound is largely healed and survival is no longer an issue.
You use a tank, Ron?
Dr. Otz, I think this brings up two questions now, and I'll answer them first with your question at this moment. Absolutely, yes. I think hydrotherapy is one of the most fundamental aspects of burn wound care, and I think the maintenance of gross wound hygiene by soap and water technique with lots of rinsing and frequent cleansings is really as fundamental as appreciating the fact that the burn wound per se is a great pablum, a great reservoir for bacteria. I think that any negative aspects of it accruing to cross-contamination are probably balanced onto the plus side by the gains of good, sound hygiene. And I will say the same thing about isolation technique. I think the burn is a physical illness. I think it requires physical handling. I see no place for isolation. All our burns are treated on open wards with good, sound, common sense hygiene, with hand washing between cases, with cleaning of tubs between uses. But to go back to the original, yes, I firmly believe in tubbing and hydrotherapy.
Before our panel takes up another area of burned wound therapy, a quick pause to signal the end of this side of your program, Doctor. Side B can be heard by just flipping over the cassette or 2 reels on your tape recorder. Continuing a program on varying views on treating the burn patient, this is Side B, Audio Digest Surgery, Volume 18, Number 4. Here again, program moderator Curtis P. Arts.
Halfway through our panel, we are ready for Dr. Baxter to tell us something about nutrition. I have a feeling that a large number of patients who die because they run out of gas. And I think the advances to come in burns probably will come in the field of better metabolism and conservation and treatment of energy losses.
I think from the work of Moore in the 40s and from the work of the Surgical Research Unit in the early 50s, particularly Dr. Saroff and associates, we have all become aware that the most severe catabolic state in the field of surgery occurs in the burn patient. And whereas after a usual or moderate amount of trauma, either surgically induced or accidentally induced, nitrogen losses get up to 30-40% above normal, or in the range of about 90 grams of protein a day, often 100-110 a day. But in a burn patient, it's well recognized that at least in the first 10 days, these losses may approach as much as 200 grams of protein per day. We have all come to recognize the components a little better of the catabolic state in the burn patient, I think principally because we now can control burn wound sepsis. The patients are not uremic anymore with rapid and successful resuscitation. And I think we can really divide these into two categories. First, the category that's the response to a severe injury, namely the catabolic response to injury, about which we know very little. Superimposed upon this in the painful burn patient is starvation after 3 or 4 days of inadequate intake, immobilization, which is commonly used in the treatment of burns, and the multiple surgical procedures that are compounded upon the metabolic injury by the coverage of the wound. In addition, in the burn patient, we have a series of catabolic catastrophes which are peculiar to the patient. Namely, we lose large amounts of protein into the burn wounds, not only initially but later. There is fever that arises from just the inflammation of damaged and dead tissue on the surface of the individual. Infection, which may not be obvious clinically, is often present in a burn patient. Certainly, when we lose skin, as Dr. Pruitt pointed out, there's an increased insensible water loss of several liters per day. For each cc that we lose, it requires a little over 1/2 kilocalorie to evaporate that cc of water. So that if we lose 3 liters a day, that's about 1,500 calories simply to evaporate that water. In addition, we have lost in the burned area the countercurrent mechanism supplied by the capillary network to conserve heat, and the radiant heat losses to the environment are extremely severe. With our present concepts of therapy, I think we can approach, before we get to nutrition, several of these things by our current management. First of all, if we rapidly resuscitate a patient, they can begin to eat adequately on the 2nd or 3rd day. If we control infection on the surface, we not only reduce the catabolic loss from infection, the patient is then capable of eating for several factors. One, they are not infected and they don't feel bad. Their appetites come back somewhat. It does not require near the amount of narcotics, and consequently the decrease in appetite that results from the administration of narcotics. In addition, all of our patients are now mobile. We do not keep even large burns in bed. They walk to the shower for their daily debridement. They walk to the Hubbard tank. They go out on the porch to watch television, etc. In addition, a field that has not been mentioned specifically is the reduction in the number of procedures that it requires to cover even a large burn. By using heterographs and homographs early, soon after the eschar is separated, and by using mesh graft techniques, we can, for example, in a 50% burn, cut the number of procedures down to an average of 3 for coverage. The first one being a big one, the other 2 being rather small. In addition to that, we can supply to the patient on the ward external heat in the form of heaters, which are now readily available. The so-called Sierrason apparatus for supplying external heat. There are cheaper ones available at about $200 to $400 a piece, and the patients are extremely comfortable as well as tending to retain heat in this manner. Again, we can decrease the time of the very extensive water loss by early coverage with either homograft or heterograft. Now specifically, first, the infection that occurs in a burn wound in general comes from the patient's own organisms, and these for the most part are from the gastrointestinal tract. So at any time we have contiguous burns through the perineum, it is almost imperative that we at least try to alter or reduce the bacterial flora, or at least control its entry into the burn wound. In this regard then, perineal burns are cleaned thoroughly with soap and water, certainly after every bowel movement and at least another time or two a day, and neomycin ointment is placed in and about the rectum. The other control of bacteria I will come to in the supplemental nutritional requirements of the patient. Now, in looking at overall nutrition, the optimal caloric ratio, in our ignorance, I would state, lies between 30 and 40 calories per gram of nitrogen to be administered. In addition, we know from multiple studies that all water-soluble vitamins are lost in burns, or used in burns, we're not sure which, in tremendous quantities, and also the fat-soluble vitamins are required in at least threefold doses. Over and above that, vitamin C seems to be utilized at a tremendous clip, so that about 1,500 milligrams a day are needed. I cannot neglect the additional needs for sodium, which arises throughout the burn course. Principally, I think this is associated with the use of hydrotherapy and the dialysis of sodium through the burn wound into the hypotonic solutions in which we bathe the patients. For reasons that are somewhat obscure, potassium losses in a burn patient exceed those of other surgical patients and require up to 200 milliequivalents a day to prevent very severe hypokalemia. In addition, we have found that magnesium losses are much more severe routinely in burn care than we had felt in the past, and we routinely employ the administration of this trace metal. So, from the second or third day on, high caloric, high protein diet, to which we would add 2 or 3 multivitamin capsules a day. There are many preparations that are perfectly adequate. The only thing that you need to look at is that they do not contain very high amounts of vitamin A or vitamin D, which might produce a hypervitaminosis state in either. In addition to that, we supply by tablet the additional quantity of ascorbic acid. We give potassium as potassium triplex or other soluble liquid potassium forms, depending on the patient's tolerance. If the diet does not contain approximately sodium in this range, we will add salt tablets and give magnesium as magnesium sulfate IM. Now, in the average 50% burn patient or large burn, we can accomplish an alimentation of around 3,000 to 4,000 calories a day if everything is going our way. We need then to add nutritional supplements, of which many are available. I can only tell you what our experience has been, and the panel might disagree as to which is the most optimal to use. We can furnish perhaps more calories with Myrtine, more protein or so with Gevrol, etc. But in terms of patient palatability, with the fewest complications and supplying calories that really get in more often, we have found that Provamalt perhaps comes closer to meeting our needs to supplying caloric demands. This can be made in a chocolate drink, which the patients tolerate quite well. The newest thing on the market, and which applies to this patient that has the perineal involvement, is a new supplement on the market, which I call Vivanex. The people who produce it call it Vivonic. It is a high caloric mixture, somewhat low in protein, but all of this protein is supplied as L-amino acids. The advantage is that, one, this is completely absorbed, so that the stool bulk is reduced to the point that often these patients have only one stool every 3 to 5 days. In addition, the supplying of large quantities of glucose on a regular basis every 4 to 6 hours into the GI tract reduces, as Swartz and Randall have shown, the bacterial population of the gut, so that we get the dual advantage of furnishing calories and reducing, at least in numbers, the bacterial population of the colon. Now, what if this patient refuses to eat? If the GI tract is intact, and we have an active GI tract that has no ileus and no evidence that it cannot absorb, we can then go to tube feedings. Experimentally now, and these will be on the market within 3 to 6 months, I'm told, are the elemental space diets that are manufactured by Swartz. The trouble with these diets at present, that they cannot be taken orally very regularly by patients since they do not taste good. I should have pointed out that Vivanex comes in 6 different flavors. It's almost as good as chewing gum, so that it varies from beef broth through orange to chocolate, etc. The elemental diet, however, is not very palatable and has to be administered as a tube feeding. The final thing is that when we have ileus and GI tract that often is malfunctioning in the face of infection, etc., we would consider intravenous hyperelementation. I think this has been a great advance in surgery to supply calories to patients in whom the GI tract or otherwise are incapable of receiving their caloric supply. At the present time, we do reserve it in burns as we do in other disastrous surgical illnesses for those patients in which we cannot supply calories by another route. I don't imply that it is all that dangerous. It has complications, particularly in the burn patients, of hyperglycemia and osmotic diuresis that may very rapidly lead to trouble unless it is appreciated, treated with insulin, or discontinuing the solution and starting again more slowly. There are complications associated with the placement of central catheters, particularly in patients with infections such as a burn close by. At Brook, currently, instead of using the usual Dudrick technique, they replace their subclavian catheters every 3 days when it becomes necessary to use it. I think it's a valuable adjunct in these patients, but should be used with caution.
Well, I appreciate your mentioning hyperelementation. I can tell you that we had a little pre-panel discussion, and not too many of the panel members are using hyperelementation at the present time, except on an experimental basis or in a few instances where they believe it is life-saving. Dr. Olstein, would you take time now to talk to us about how you prepare and graft?
The cure of the burn disease is ultimately achieved by providing skin cover. And I personally have always looked upon the treatment of burns as more or less a two-pronged assault. On the one side is the massive physiologic therapy of which Dr. Pruitt and Dr. Baxter spoke, in which one's dealing with intravenous fluids, whole blood, antibiotics, steroids, oxygen therapy, vitamins, high protein, high calorie diets, hyperelementation, all of what we think of as essential to supporting an extremely sick patient. But in fact, the patient ultimately is not cured of his disease and literally cannot turn the bend and have his hole in his gas tank plugged, if you will, until he has been provided with a new skin surface. The skin surface, when it's burned, to me is literally a hole in a gas tank. No matter how much you pour in, you can only hope maybe to stay abreast of the leakage. And the only real way to cure the disease is to plug the leak. When we discuss the subject of how to prepare a burn surface for skin grafting, we're really talking about a subject which we just touched on, which is local burn wound care. And I must say that I could sum up my burn wound care easily by speaking as an extremely conservative surgeon. I have found little use and little need to perform any major surgical procedures on a patient prior to the first autografting. Bedside debridements are a basic part of my therapy, but any attempts at early radical excision of burn wounds, tangential excisions, or major operative debridements in the operating room and under anesthesia have not been part of my therapeutic program. And so I basically do follow an extremely conservative line, which consists of many of the fundamentals of which the panelists just spoke. Perhaps going through a case would make it a little more vivid. The youngster was burned on Washington's birthday a few years ago, having been playing with matches and, fortunately for him, wearing only the top of a pajama, which was that typical cotton flannelette, which literally exploded when he dropped a match on it. 12 hours following his injury, he's simply exposed with what appears to be a rather deep burn injury. It is a flame burn. It was sustained indoors. There was a history of burning clothing. And up to this point, which is 12 hours, getting intravenous fluids, he has a long catheter in his lower extremities, Foley catheter. He's in no airway difficulty. His wounds have been cleansed gently with dilute soap and water. We generally use something like ivory liquid in warm water, sponged off, the loose debris, dead epidermis, etc. removed, and he's been coated with topical sulfamylon, applied with a sterile gloved hand over all burn surfaces, front and back. There's not much question that this is a deep and destructive injury and probably approximates 40% body surface area. 9 days following his burn. Now, up to this point, he's been weaned off his catheters. He's taking a pretty good diet by mouth with vitamin supplements. He's been on a couple of courses of antibiotics. He's getting the best that we can give him by mouth in terms of high protein, high calorie diet and vitamins. He's being washed at least once or twice a day with dilute soap and water, just cleansed down and rinsed off with a little water. And somewhere between 2 and 4 times a day, he has the topical sulfamylon applied. And we see frank necrotic tissue. When you talk about preparing a wound for autografting or for skin grafting, what you're really talking about is eliminating the dead tissue, which is the bacterial pablum, which is so destructive to the patient, and allowing the underlying viable tissue to granulate. And it's the granulation tissue that provides the vascular budding, which ultimately incorporates the skin autografts to provide a new epithelial surface, the cure of the disease. At approximately 29 days post-burn, we have achieved the beginning of satisfactory granulation tissue. We vary somewhat in our technique in terms of topical care. Many men will use the topical antibacterial agents up until the time that the grafting takes place. We hear a lot about eschar separation delay, but to me this is merely a product of good antibacterial therapy. That is to say that the eschar inevitably separates because of bacterial proteolytic enzyme activity. The more sloppy a wound, in all likelihood, the more rapid the eschar will separate. So we accept some delay in order to compromise bacterial activity and protect the patient against sepsis during the period when the patient does possess a large pablum. But once the eschar, the big, thick mass of dead tissue, begins to crack or curl, which is somewhere around 3 to 4 weeks following injury, 21 to 28 days, we stop the topical antibacterial therapy in those areas where the eschar is separating and we're starting to get some drainage. We keep the topical sulfamylon going in all areas where the eschar remains thick and hard and dry. But where it begins to separate, we stop it and we go to an age-old method of cotton-free gauze pads or cotton-free gauze cling or Curlex rolls, depending upon the part of the body, soaked in saline, changed every 2 to 4 hours. This provides free drainage of material, mops up the exudate, and with each change provides the debridement, which is so essential to reducing the problem of a bacterial pablum and sepsis. This is accompanied by the daily bathing in the soap and water solution, or the bathing in bed or in a shower or tub as the patient permits, and is continued right up until the time that we feel we have achieved granulations that are flat, red, take the imprint of gauze, show marginal epithelialization, which is always a good sign of a ready granulating wound, one that we feel is receptive to skin grafting, because I do think that that initial skin grafting in a major case literally must be successful. You can't have halfway takes, you have to have near complete takes. Daily bedside debridements with the scissors and a forceps are used along with appropriate analgesia, usually Demerol. And at approximately 34 days following the initial burn injury, the grafting of the posterior burn surface, that is the back, we make a great point out of grafting in continuity. That is to say that we will take an area and prepare it and try to select our donor sites so that when the patient is positioned properly in bed for the take, the quiet take of the skin grafts, that his donor sites are not further traumatized. So in a case like this, we will use the posterior surface of the thighs and legs and resurface the back in sheets or stamps as the case may be. And when those grafts are stable enough, which certainly requires 10 to 14 days for adequate connective tissue bonding between the graft and the recipient bed, and the donor sites on the posterior lower limbs have healed sufficiently to permit the patient to be rotated 180 degrees, we do exactly the same procedure using the anterior lower extremities to the anterior burn areas, and basically in a matter of 14 days have turned this burn into a relatively non-threatening type of illness. Now, I'd like to make one additional point which has proved very effective in our hands, and that is that we have adopted the procedure of either doing the taking of the skin grafts under local or ketamine or general anesthesia on the operating room table. We will then hand the grafts off to the assistant or the nurse, who will cut them or fashion them as we've previously directed, either leaving them as large sheets or cutting them into smaller stamps. In the meantime, we put the patient back in his bed, which is brought up to the operating room. All the sheets, the bolsters, the pillows are all in order. We turn the patient into any position we wish him to remain in for the next several days, the critical time for graft take, while the capillary buds must get a hold of the skin grafts and establish a true circulation. And then, with the patient in bed, awake, without any anesthesia, we reapply our skin grafts with no further manipulations. The grafts are covered with adaptic gauze and saline-soaked gauze pads, or in the case of the limbs, perhaps we would use a roll-on gauze roll like Kling or Curlex, and they are changed frequently down to the adaptic to get rid of that inevitable exudation, but the adaptic is not disturbed unless essential.
Now, we have a few minutes left, and I have a number of questions. I've tried to group them. I'll get you some opinions. First, what about the individual with respiratory tract injury? I think we're all scared when the patient comes in having been burned in a closed space and they have black around their nostrils and they're a little bit hoarse. Dr. Olstein, if you make a diagnosis of tracheobronchial injury following a burn, what do you do to treat it?
With a frank respiratory tract injury, we go immediately to checking the patient's mentation and his ability to breathe. If he's breathing reasonably comfortably, even though he may be coughing, maybe spitting up some soot, we'll be certain that he's clean, be certain that he's not choking on anything, and administer oxygen, usually by nasal catheter technique. Occasionally we'll go to the mask, and the oxygen will certainly be bubbled through a humidifying solution. Whether or not it contains medications is something else. If we have not gotten the relaxed patient that we want, if the patient remains anxious with a rapid rate, with obvious difficulty in breathing, listen to his chest. If he has noises and squeaks, get the chest x-ray, may or may not have changes. We will keep him on an oxygen humidified regimen. We may go to the use of IPPB on the bird with a cooperative patient. But if the patient is in any way uncooperative, or if we're really frightened and maybe we've gotten an oxygen tension in the blood which is getting low, I will administer intravenous steroids rather promptly. And I do this by using hydrocortisone 1,000 to 2,000 milligrams in a shot, usually taking about 10 to 15 minutes and a small amount of saline, given as often as necessary until I feel that the respiratory situation has improved. And this may be as often as every 2 to 6 hours. If I feel that that per se is still not getting across to the patient, he still looks like he's in great distress, a tracheostomy, the use of a mechanical ventilator, and the use of topical medications as well as antibiotics and steroids would be continued.
How many people on the panel use steroids once they make the diagnosis? 2 people do, others may not. How many do a trach as soon as they make the diagnosis? Dr. Baxter and I agree. I maintain that if you think the patient and make the diagnosis of respiratory tract injury in a patient, you have 3 things to do. You give them steroids, you do a trach, and you give them antibiotics. Now, how you make the diagnosis, I can't say. This might take a long, long time. There's a question, do you use ketamine for burn patients? Yes, I think all of us use ketamine for burn patients, and we're really impressed. I'm personally impressed that you can do a large number of things. You can debride wounds, you can change burn dressings. If you do dressings, you can take skin grafts with ketamine, and by and large, it's just tremendous in children, and our own personal experience has been that it's fine in adults. I think they should be prepared a little before, and there are some cases of hallucination in adults after ketamine, but by and large, it's very safe, and it's a wonderful drug for the minor procedures, or the procedures that take a relatively short time. Dr. Pruitt, how do you manage burns of the dorsum of the hand? I think we've mixed up the world on this. Some have said excise, some have said don't excise, some have said splint.
Our general treatment is conservative, that is, again, topical chemotherapy with control of infection. And I think that excision should be limited. Perhaps there's still a role of primary hand excision, but it should be limited to those hands in which it is clearly a rather superficial injury. By that, I mean full thickness skin, but it does not involve the extensor mechanism. The difficult part in deciding on whether a hand should be excised is to make the clinical assessment before undertaking surgery as to whether the extensor mechanism is or is not involved. In our experience, in those hands in which it is, primary excision and an attempt to cover that with graft has merely opened up this unprotected tissue to bacterial complications and further tissue and function loss.
Dr. Hart, may I
Yes,
emphasize one other thing? We treat hands conservatively also, but I would like to emphasize that a program of active physiotherapy during the day and night splinting in a position of function, in addition to the topical chemotherapy, I think will produce the largest number of good results.
Do you use cold sponges immediately after injury? I believe this is very clear now. There is abundant evidence, both in the laboratory and from years of clinical experience, that the best thing you can do immediately after a burn, not 6 or 7 hours, I don't believe, but immediately after a burn, to give that patient comfort, is to put on bath towels or some heavy cloth soaked in ice water. And if you'll keep that cold for a period of time, you'll not only take away the pain that is there, but you'll actually stop, if you get it early enough, much of the burning insult. The immediate treatment for all burns is cold, if you can get to it immediately. And the final question I'd like to ask is, when should you refer a burn patient from your hands, from your hospital, to a burn center? We have now developed a number of burn centers around over the country, and I think every one of us in them has a feeling that many times they come in too late, or many times it really is probably unnecessary. Dr. Baxter, you've had an abundant experience now at Dallas. Just tell me, if you were in a community hospital, what kind of burns would you refer to a good center?
I think oftentimes it would be variable as to the facilities that a given surgeon had available. I don't believe that my answer is based upon the individual capabilities of any of our colleagues. But in the hospitals that I've visited where burns are taken care of and the organization and team effort needed, it appears to me that we should draw a line, or can draw a line, around 30%. That this seems to be the point at which mortalities begin to occur more than they should in the usual surgical type of hospital. I might add the less than 30% burns that involve such special areas as the hands and the face, electrical burns and respiratory burns should probably be added to that list.
To all of you panelists, to the audience, thank you very much.
And so concludes another edition of Audio Digest Surgery, produced and copyrighted twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. Our thanks to the speakers and to you for listening, Doctor.